I'm going to continue with my talk. My name is Dr. Katharina Brosch. I'm a postdoctoral researcher at the Feinstein Institute for Medical Research in New York, and I will be talking to you about effects of secure attachment and childhood maltreatment and how these two interact. I have no disclosures. Before I start presenting my research, I want to say thank you and give credit to all the people who have contributed and helped in collecting and analyzing the data. I want to thank my mentors and co-authors, as well as the study participants of the study that I'm presenting today, the German 42107 cohort study. It's 9 in the morning, and we're going to start with a little statistics refresher. When I went to look at interaction effects in nature, I could measure the effect that the rainfall, the amount of rainfall has on my well-being, on my happiness as a main effect. I could also look at the effect of the amount of sunshine, how the amount of sunshine affects my happiness. But when I have two main effects, I can also look at the interaction effect of these two. Very surprising. This is a rainbow. And in statistics, we talk about an interaction effect or a moderation when two variables interact in such a way that it's more than just the additive main effect. So I just wanted to give you a little quick reminder in case the statistics been a while. So looking at the bright side, when we look at secure attachment, we know it's a very important risk factor. It helps us form stable relationships, and it enables us to navigate both intimacy and distance in relationships, which is necessary to form robust relationships, because we need both. We know that it's associated with fewer depressive symptoms and higher relationship satisfaction, which makes a lot of sense, right? We also know that different brain structural changes have been associated with different types of attachment. This theory comes from Bowlby et al., who has described 4 attachment styles, and he has described, so the preoccupied, dismissing, and fearful attachment styles can be grouped together as insecure attachment styles compared to a secure attachment style. And in order for an individual to form such a secure attachment style during childhood, one needs to have a positive image of self and a positive image of others. You all know, when we're looking at the rain, at the negative side, that childhood maltreatment is a very prominent risk factor that makes us that puts us at higher risk for depression and depressive symptoms. Within depression, we have a worse trajectory when childhood maltreatment is present. In a relatively recent meta-analysis, they looked at it from the other way around. They looked at individuals with depression, and they reported that almost half of individuals with depression report some form of childhood maltreatment. We know that childhood maltreatment is associated with brain structural changes, and when we look at these changes, within healthy individuals, these are already similar to changes we see in patients with depression. This is why Dr. Teicher has called us, for us to consider childhood maltreatment as like its own separate ecophenotype, because it comes with so many pervasive, adverse consequences in terms of epigenetics and inflammation and brain and functional changes. Okay, so putting these two things together, putting childhood maltreatment and secure attachment together, it's more difficult to form a secure attachment style when you have experienced childhood maltreatment, because you don't have this experience of knowing that others can be safe. However, we still see individuals with maltreatment who manage to be securely attached. So we can think of these individuals as interpersonally resilient, which is remarkable, which is what we want, right? But it's more difficult for them to form that secure attachment than it would be for someone with no experience of childhood maltreatment. In my research, I was interested in how attachment style and childhood maltreatment would interact to influence both brain and behavior. And why should we even look at interaction effects? Well, my lab has previously published work in both gray matter and white matter, showing comprehensively that there is an effect for interaction of risk and diagnosis, like a resilience effect in individuals who are at high risk. So that would be familial risk for depression and childhood maltreatment, but are still healthy. So healthy control, high risk. So we thought, let's do it again. My sample consisted of over 1,000 individuals from the German 42107 longitudinal cohort study. They were about 35 years old. And in our sample, we assessed childhood maltreatment and attachment style dichotomously. And when we do that and we put these groups together, this actually gives us 4 groups. Whoops, sorry. Oh, no. There we go. This gives us 4 groups. And I just want to draw your attention to the first group. Okay. The no childhood maltreatment and securely attached. That's my biggest group, and that makes sense, right? If I don't have any childhood maltreatment experiences, it's easier for me to form a secure attachment style. But underneath that, we also have individuals, and that was the smallest group here, who managed to be securely attached despite experiences of childhood maltreatment. So these are the interpersonally resilient individuals, and very interesting. I looked at 6 behavioral brain outcomes, which were self- and rater-based depressive symptoms, symptom severity, perceived stress, resilience, which is self-reported, and global assessment of functioning. And I looked at voxel-based morphometry, specifically at gray matter volume. Okay, I'm not going to keep the results from you any longer. When we look at the behavioral outcomes, at the 6 behavioral outcomes, we see what would be expected. So we see main effects for all of these 6 outcomes for childhood maltreatment in the way that you would expect. So they're more depressed, less resilient, have higher symptoms, more stress, lower functioning. But we also see, and this is already very promising, we also see main effects for all of these measures for the attachment style in the exact opposite way, right? So securely attached individuals were less depressed, had higher resilience and higher global functioning, less perceived stress. And usually, and I just want to reiterate that we usually just lump the green and the yellow in together, the people with childhood maltreatment, but they're noticeably different in all of these measures. So much so that we actually saw 3 interaction effects on top of these main effects. And we saw them in global symptom severity, self-reported depression, and global functioning. The way you can interpret this is both ways. So you could say the securely attached maltreated group is almost comparable to someone with no childhood maltreatment, whereas the group with insecure attachment is worse off with higher global symptoms, higher depressive symptoms, and much lower global functioning. And that just reiterates the point of really looking at these protective factors as well, because it does make a difference. When we look at the brain, we found an interaction effect as well in the left supramarginal gyrus. And interestingly, here we did not detect any main effects for either maltreatment or attachment itself. And these findings are in a way that securely attached maltreated individuals have significantly higher gray matter volume in the left supramarginal gyrus compared to all other groups. We're not 100% sure what that means yet, so if you have any thoughts, email me. This region is associated with mirror neurons, and it might enable maltreated individuals to adaptively navigate relationships and help in like maintaining a secure attachment style. So to just give you a summary of what I've just told you, we see main and interactive effects for risk and protective factors, and it makes sense to look at them together because these interpersonally resilient individuals, they have better outcomes. They have fewer depressive symptoms, lower symptom severity, they're like higher functioning, and they have like a brain correlate as well. So hold each other tight. I want to use the rest of my remaining time to talk more globally about why I chose to put the symposium together, because I feel very passionately about including protective factors into our research. And I've just brought you a few examples of what you could be doing with your research. You could be looking at running therapy, where Laura is a co-author. You could include protective factors in more complex association networks. You could look at social support next to stressful life events. You could look at moderating, which is also an interaction effect. And I just want to show you that this really changes the narrative, because we will go from just looking at the negative and looking at also what's working. Protective factors are not a one-size-fits-all. I hope Matthew forgives me, but meditation is not going to solve all our problems. So we should look into what helps specific populations. There might be differences between the sexes and the genders. There might be individual level protective factors that are not suitable to counteract systemic issues such as racism. But looking at these protective factors gives us a more holistic picture of who's actually at risk and what is helping and what is not helping. Just to reiterate that point, I've also done research during the COVID pandemic where we were able to show that highly conscientious individuals were more anxious. So in certain settings, specific protective factors or things that we think of protective might even be harmful. So I encourage you to include these in your research. Just to give you like a little overview of what else you could be looking at, this is a list of multi-system resilience factors, because mental health is not just the absence of illness, it's also about thriving, about happiness, and we're better able to grasp these concepts when we look at protective factors. We could also be looking at the other side of the coin in terms of adverse childhood experiences. We could be looking at benevolent childhood experiences. All right, so in summary, let's look at the bright side. We will be able to provide a more comprehensive picture of who is actually at risk. We will be better able to explain why some people manage to maintain mental health. There's a lot of things that we don't understand. There's the Hispanic health paradox. We don't know why these individuals are so resilient. Even in mice, I think that's a very striking example. When you try to induce learned helplessness, you only manage to do it in a third. And so if you can't even do it in the mice, like, you have to consider that we're much more complex. We have these protective factors that actively help us stay healthy, and we need to be looking at them. It will enable us to identify what things work and what don't. We can't change childhood maltreatment, right? And we have shown comprehensively that it's terrible. We don't need to reiterate that it's terrible during pregnancy and during the COVID pandemic. We need to include protective factors because that will also give us a hint into what we could be doing in terms of prevention and intervention, because these protective factors are often malleable. We can tell people you should exercise more, we can teach people to build better social networks. It allows us for the investigation of interaction effects. And that last one is something that I'm very passionate about. It will also change the narrative that we're currently perpetuating over and over again. And it will move the field forward from a deficit-focused view of an individual more to a resource-oriented view. And that is also very important to avoid further stigmatization. Yes, and with that, I would like to conclude. I feel very passionately about this. If you have questions, comments, if you would like to collaborate, please reach out to me. I would love to hear your thoughts. Yes, and if you have questions, please come up.
Thanks a lot. That was a very conceptually interesting line of research. I wondered how you operationalized trauma, because there's many ways how you can derive that from CTQ apart from the problems inherent to CTQ as a measure. But did you build the subdomains and count these subpoints, or did you have an absolute threshold?
Yeah, that's a great point. Thank you. We used the childhood trauma questionnaire, and we used the validated cutoff scales for the 5 subscales of the CDQ. And if an individual reported going over the threshold for at least one of the subscales, we considered them as with childhood maltreatment. So it's a very low approach. You could also go higher. But what I think is really interesting, that even if we take such a low approach, we still have pronounced effects that we can see in both brain and behavior, right? So even if we set the threshold relatively low, we see that childhood maltreatment has an effect on all of these outcomes. Thank you. Okay, great. Thank you. We're trying to figure out the app. So if you're a little camera shy, but there's no questions in the app, but I encourage you to ask questions in the app as well if you don't want to come up. All right.